for long, ladies and gentlemen, because it's not me that you really want to listen to. We've got two really excellent speakers today who can talk to us about reasonable adjustment and the personalisation agenda in the context of learning disabilities and autism. I'm sure equally some of the principles and some of the things that they will talk about will apply to mental health as well, but that's not my area of responsibility or portfolio. So I will leave it to my colleagues within the mental health team to add anything if they feel that it's necessary. I'm ever so sorry, I need to apologise. We should have had a third speaker for you today to talk about the digital flag, but for some reason there was a bit of a muddle with the agenda, but we'll make sure that that happens for you in the future as well, so you've got more information about that, because I will refer to it briefly. So in terms of reasonable adjustment from a learning disability and autism perspective, I think we're all mindful through the Learning Disability and Autism programme that there has been a commitment to make it easy for all disabled people to access and use health services in the same way that you and I would expect to do so. So specifically around learning disability and autism, that does mean that we will be working and there's an expectation that people with a learning disability and or autism are registered on the QOF GP register at their local practice. I think just some headlines there at the moment, because we will be initiating some conversations with colleagues, SROs from the Learning Disability and Autism programme, is that currently the national prevalence for learning disability is 2.5%. And I know this is arbitrary and there's a variation in terms of prevalence across the country. There's not a standard prevalence rate across all of our localities and all of our systems. But at the moment, we are currently recording between 0.3 and 0.4% of that population on our learning disability registers. So we've got a little bit of work to do in respect of increasing the number of people on those registers. A part of that, and closely linked to that, the last bullet point there is about undertaking the annual health checks, and that is about making sure that when they're doing them, it's not just about ticking the box, because that's, if we do that, we're hitting the target, but we're missing the point. There's something a bit more for me, and that's why I've asked Marie to join us today, and that's about what if. What do we do once we've done that annual health check? And it's about putting in place, or is there an option, a possibility to use and to link up the use of personal health budgets and our social care prescribers that are currently sitting within our PCNs to support the recommendations made in those annual health checks. Part of those annual health checks is around screening and immunisations, and with a particular focus at the moment on the flu vaccination and encouraging GPs to use the opportunity to make sure people with learning disability and autism have had their flu vaccination. And then the other thing is around additional information around their summary care records. And this is kind of where it linked to the digital flag and the reasonable adjustment flag that I referred to a few minutes ago. So if we could move on to the next slide, so how we will do this. I've talked about the QOF register. I've talked about sorry, I'm just moving my slide down as well, coming back to the reasonable adjustment flag and how we make sure that healthcare staff in any setting, not just in a primary care setting, in any GP not just in a GP setting, but in any setting, any acute hospital, mental health hospital. So there's some sort of flag about making sure that the people that they are interacting with understand that there is a reasonable adjustment required, and that's where I started to talk about the reasonable adjustment flag and the digital piece of work that we will be hearing more about later in the year. And then again, there's something we can do around making sure that we've got accessible information and how we use easy read information. So there's a whole bundle of opportunities there that we can use. If we can move on to the next slide to look at how we make that reasonable adjustment. And Tom, who's joining us today, is going to talk about a fabulous piece of work that he's recently undertaken with a mental health provider in Norfolk and Suffolk about reasonable adjustment. And we have been fortunate to get permission from Norfolk and Suffolk Mental Health Trust that they are going to share that, that manual, if you like, that they've produced about good practice around reasonable adjustment in all healthcare settings. They're going to share that with us in the South East, and it's something that we'll be sending out to you. And as we start to move forward with the quality agenda and looking at improved outcomes for people with learning disability and autism, it will be something that we'll want to continue to work with you and support you in terms of working with providers to make sure those reasonable adjustments and those recommendations are being put into place. So coming back to personalisation then, and our links and the opportunity here and how we can align that to annual health checks. I know Marie is going to talk about a cross-organisational learning disability programme that's working to make sure that people live in homes, people who are have their annual health check are offered the opportunity to use a personal health budget to support them in implementing and delivering and living through those outcomes that are recommended as that annual health check. So then the other piece I think that is really important, and one of the key drivers, it shouldn't be the key driver because it is absolutely the right thing to do in terms of making these personal health budgets available to people with learning disability and autism, but it is around the fact that the National Long-Term Plan has actually identified that we need to use these opportunities, and there's an expectation that we increase the uptake of personal health budgets within the learning disability and autism cohort. On that last slide, there are a few references there that people can access. There's some really good stories up on YouTube in terms of how personal health budgets have been used and put in place, and some really good stories told by people with lived experience about how they've benefited and improved their outcomes and improved their experiences of living independently in the community. So I'm going to pass over to Tom now, I think, who is going to talk to us about his reasonable adjustment work that he's done with the Mental Health Trust. Then we'll come to Marie, and as I say, on another day I will bring back a gentleman called Stephen from NHS Digital, who has led on a pilot in the Southwest in terms of implementing the reasonable adjustment flag, so making sure that people who are working with people with learning disability have got know that they need information and have got additional information needs on top of you and I. So I'm going to hand over now.
Thanks, Alison. Yeah, hi, my name is Tom Evans. I work for BILD. I'm the Positive Behaviour Support Lead at BILD, but we were commissioned by Norfolk and Suffolk Trust to produce a manual, reasonable adjustments for people with learning disabilities and autistic people. One of the reasons for that was they were talking about needing to make reasonable adjustments, and the question that often came back was, well, what do we do? How do you do that? Is it just about easy read? Is it just about ramps into buildings? So we wanted to produce a practical tool that can be used by anybody in any health setting, currently in any health setting, soon to be expanded out to any setting, but at the moment any health setting. We started off by looking at all the advice that was out there in the public domain, reviewed it all, identified the gaps. We also did a literature review, the literature talking about the effectiveness of making reasonable adjustments and the impact it had on health outcomes. And we also looked at what the law said. So the next slide gives you the full contents of the manual. The first part, it is a really practical tool. There are tables throughout it, and the idea is that an individual clinician or staff member can audit themselves to make sure that they, as an individual practitioner, are making the reasonable adjustments that autistic people and people with a learning disability need. And then there are actions that a team or a service or a setting or a ward also need to be making. So in each of the sections here, there are tools that either an individual or a team can use to audit where they currently are. So the idea is they work through the manual, and then that turns into an action plan, which shows them what they need to be doing over the next 6 months and 12 months. So the introduction just literally talks about why reasonable adjustments, why we need to be doing this. You then go into the values around reasonable adjustments. The first part then that people get to in the manual is the views of people with learning disabilities. So my colleague Kate, who works with me at BILD, she's a woman with learning disability, and she's part of a service user group. So I asked her to go to the group and ask the group what, from their point of view, what are the most important reasonable adjustments that health setting needs to make? And they gave us a list. So that's where we start, because that's the right thing to do. We then go into general principles. So I was really interested to see the slide on personalisation, because the general principles you can put into a few groups. I mean, the views of people with learning disabilities come first, obviously. There's then a section on the overall approach of health professionals, which talks in a very broad sense around some of the values, some of the principles that need to be in place. Then going on to personalisation, partnership working. So point being, most important aspect of reasonable adjustments involves asking the autistic person or the person with learning disabilities or their supporters what adjustments they need or want, rather than just assuming that everybody with either of those diagnoses need the same reasonable adjustments. There are, of course, reasonable adjustments that benefit most people, but individuals may need specific reasonable adjustments, and that's what needs to be included on their records. So after personalisation, the next section we look at is preparation. So making sure that if people are going to access healthcare, there needs to be forward thinking, there needs to be planning. So rather than waiting for difficulties to arise, the duty on health services is anticipatory. So you need to be thinking about what might be likely and planning the adjustments before all appointments and treatments. There's quite a lot in there on desensitisation and the impact that can have on people getting the healthcare they need. When you look at the literature, though, and when you look at all the good practice out there, the reasonable adjustments that are needed come into three broad sections, categories, if you like. The first is around communication, how we communicate, and obviously that includes easy read, it includes signage, it includes how we talk, it includes what we say. The second broad area is around our systems and processes. How do we provide healthcare, and what are reasonable ways of changing how we do what we do? And the third broad area is around the environment. So the physical environment's really obvious. We know about ramps, we know about grab rails, we know about lighting, particularly important for a lot of autistic people, but it's far broader than that. So that section talks about the changes in the environment. That's not about knocking down walls and changing, although if you have the opportunity to do that, fabulous, but it's about how we can make changes to the existing environments easily and quickly and simply. There's some key principles in there that can be applied to any setting. The next section is looking at specific health service areas. So there's a lot of guidance out there that's been produced over the last decade. So there's a section there on phlebotomy, there's a section there on cancer screening, there's a section there on drug and alcohol services, whole range of specific service areas. So the principles and the adjustments that come under communication and processes, systems and environment, they will apply to any health setting. And then section 6 looks at what else specific service areas may need to do. Section 7 is the literature review, of interest to some people, by no means everyone, but kind of talks about the evidence base and the effectiveness of making reasonable adjustments. And then section 8, again, will be of interest to some people, maybe not everyone, but summarises the key laws. There's 6 or 7 laws in the UK that all refer to reasonable adjustments. So there's a quick summary there of what the law says. As I say, the manual is very much a practical document. So in each section, it lists a reasonable adjustment. For example, under capacity to consent, all clinicians have a good understanding of the process of assessing capacity in the consent process and the need to provide accessible information and simple simple, accessible information in order to support people to make decisions and consent or not to treatment. And then for that standard, so it's that there's a whole list of standards throughout the manual. It then asks you, where are we now, and what else do we need to do? So those questions are asked, as I said before, to an individual, but also to a service. So an individual can audit themselves, completely on their own. Where am I now? What else do I need to do? Where am I now? Yes, I meet that standard completely. Or no, I don't meet that standard completely. So therefore, what else do I need to do? And the same principle then for teams of people or groups of people. So the idea is that individuals and teams will work through this in however long it takes, and that will then produce for them, either as an individual or for a group or service, an action plan of what they do, what they need to do to get in line with the law and the values and the principles of reasonable adjustments. That's the gist of it. In terms of what it's actually going to look like, in Norfolk and Suffolk, there will be hard copies in services. It'll be a loose leaf file, so people can take out individual sheets to complete themselves, but there'll always be the hard copy there as well. It'll also be electronic, and it'll turn into drop downs and that sort of thing. So I'm delighted that they were willing to let us, to use their phrase, get it out there more broadly, so that this can be used in any setting. As I say, they've also now commissioned us to extend it to social care settings, which isn't a big piece of work, to be perfectly honest. If you look at it, you will see that the vast majority of this also applies to any other setting. So we're hoping that this is now we all know we need to make reasonable adjustments, but this actually tells people how to practically do it. And it's thorough and it's rigorous, and it's based on a good review of not just good practice, but what the law says, what policy says, and also what people with learning disabilities and autistic people tell us they want us to do. So I think that's all I want to say, unless there's any questions.
Hi, thanks Tom, that was fabulous, and we're really looking forward to seeing the completed manual and being able to share it with everybody. Are there any questions from anyone? No?
Nothing in the chat at the moment.
Stunned silence. Okay. Catherine, you've got your hand up.
No, sorry, I was just going to say I've literally just joined towards the end of that, but what I'm seeing there, Tom, absolutely wonderful. I think it's something we've needed for a long time, and I think it will really help us to articulate with our other colleagues across the system exactly, because I don't think they really don't necessarily understand reasonable adjustments, and I think we take it for granted because we know, because it's our knowledge base, but actually sometimes defining that and describing it to other people is the challenge.
Yeah.
So thanks for that. Yeah, really appreciate it.
To me, we need to make things usable. They need to fit with the context, and they need to be useful for the people who need to use them. So it needs to be practical and easy to understand, but also with the requirement that it is followed.
Can I ask, does it have an audit tool potential at the end of it, so that services can audit themselves against it?
Yeah, that's how it's structured. So there's a list of standards throughout it that an individual clinician and then the team audit themselves. Where are we now? What else do we need to do? And then that transfers into an action plan, which is in the appendix. So you could then have a service action plan for meeting all the standards in it.
Okay, so in terms of the GPs and primary care QOF QP, one of the things in there is their learning disability audit that they need to do against their practice for reasonable adjustments. So they could actually present this to the primary care and say, this is what you need to do, and make it, because that's what they need, is they need that simplicity of knowing this is what we're measuring ourselves against.
Yeah,
it's really helpful.
Absolutely, Catherine, they're really good points, and I think I'm really excited about this and looking forward to receiving it. As I said, what my intention is to do is to see how we can work through the systems and support you in developing a quality kite mark across the whole of the South East, and that quality kite mark, once awarded, would demonstrate that those reasonable adjustments have been made and put in place, in the same way that we've done a similar thing with the dementia. Was it a Daisy? Someone going to tell me what what flower it was. And I was looking at seeing if we could adopt the marigold for learning disability and autism, because I know it's the flower that has been adopted in quite a few of sort of regular businesses. So airports, Sainsbury's, some of our other supermarkets, for example, use the marigold to demonstrate where reasonable adjustment has been made, or to highlight, or to flag up that somebody has got additional communication needs. Or so I think it's being used on the lanyards as well for the mask exempt population as well. So it's something that I'm kind of in the back of my mind in terms of how we can use it and how we can encourage people and support this to happen across the southeast. So any other questions? No. Okay, so Marie, are you with us?
Yes.
Oh, that's great. Okay, so I think somebody is driving your slides and has got your slides in the background as well, and we can share those for you.
That's great, thank you.
And then we can move into the presentation around personalisation.
I don't know who's got. I've given Jack the slides. I don't know if it's Jack.
Yeah.
Yeah.
Jack, are you on the call?
I am. Yeah, I'm just wondering if Jan's got it in the background. If not, I'll jump on.
I'm afraid I don't. I haven't got that one.
No problem. There we go. Can you all see that? Hopefully it should be on your screen now. Sorry for the delay.
Yeah, I can see that now. That's great. Thank you.
Zoom in. There we go.
Great. And good afternoon, everyone. If I'm panting, it's because I've literally just bombed it back after a mad dash across East Kent. So my name's Marie Reynolds. I work in the Personalised Care Group within NHS England and Improvement, and I'm a delivery partner working with systems in the South East to help them to expand their capability for personalised care delivery. Can we move to the first slide, please? That's great, thank you. So I want to just take a few minutes to give an overview of our personalised care model. We've developed the model with a number of organisations across health and social care and the voluntary sector, and also people who use services, people with lived experience. And it brings together a number of interventions across the personalised care landscape rather. And it is a all-age, whole population approach to personalised care. So it hopefully helps people to understand how it can be delivered. At the end of the slide deck, I've provided some additional resources and links. So there's a link to the document, which is the Universal Model of Personalised Care, if people want to know more. So personalised care gives people more choice and control over how their health and wellbeing needs are met. It looks at particular universal interventions for the whole population, such as shared decision making and choice and social prescribing and access to community-based support. In the middle is the second group of people with long-term physical and mental health conditions, and that accounts for about 30% of the population. And they're supported with targeted personalised care interventions, such as personalised care and support planning, which helps them to identify a more appropriate targeted interventions such as patient activation, support around self-management, so peer support and education as well. And at the top of the triangle are about 5% of the population, so those people with more complex needs. And there are specialist interventions for people in that group, and they are things such as personal health budgets and integrated personal budgets. So if we can move on to the next slide, please. So this is a resource that was developed with our strategic co-production colleagues, and it aims to describe the shift in relationship between health and care professionals and the people that they support. It tries to describe what the experience of being on the receiving end of good personalised care looks like. And I won't go through all of it, but it's quite a nice slide because it helps to think about things in a different way. So rather than thinking about what's the matter with somebody or focusing on a collection of symptoms or conditions that they are managing or living with, it talks about what matters to people and looks at a more holistic view. Also, it sort of aims to shift people from feeling powerless in quite a complex health and care system to sharing power with health and care professionals that support them to help them feel more empowered and more involved in their decisions about the care and support that they're provided with. Next slide, please. Brilliant. You've anticipated me well there. Thank you. So personalised care is one of the key shifts in the model of delivery for the NHS that's outlined in the long-term plan. And I just wanted to highlight, I don't want to worry people too much with the trajectories in this slide, and it's very busy as well. But in the long-term plan responses submissions, all of the systems will have provided trajectories that help us to track their progress towards delivering on the ambitions in the long-term plan. So that's on looking at key metrics around numbers of social prescribing link workers that have been recruited and trained, referrals to those link workers, looking at how many people with long-term conditions have been supported through PAM or supported self-management, how many personalised care and support plans we have in place, how many PHBs we have in place, and also looking at the workforce, how many people in the workforce are supported and trained to deliver personalised care well. Thanks. Next slide, please. We've also more recently started to think about how the personalised care, how personalised care can support phase 3 planning and restoration and recovery. So basically, this is around sort of. It was also highlighted by National Voices as one of the key principles for the next COVID, the next phase of the COVID response. We feel as well that it can be a key enabler in addressing inequalities through proactively engaging people at the greatest risk of poor health outcomes using an integrated and personalised model of care. Next slide, please, Jack. Sorry if I'm rushing. I'm trying to get through some of these so that we can give more time for discussion and questions potentially. Again, the next two slides kind of go into that in a bit more detail. So it's taking the key principles around recovery and aligning them to those personalised care interventions. So thinking about prevention, that's the kind of whole population aspect, looking at social prescribing, potentially looking at personalised care and support planning as well and how they can be used together, accessing health and wellbeing coaches, that kind of thing. Looking at how we can use components within the model to support and protect the most vulnerable and to stay well at home. Thinking about potentially looking at patient activation measures to risk stratify or support risk stratification of waiting lists so that we can support people to build their skills, their knowledge, skills and confidence to manage their own health and well-being. If you can move on to the next slide, Jack. And we've also looked at aligning the model to things like the discharge to assess process and guidance. So again, we've done some work with Surrey Heartlands to look at how they can use social prescribers to support people who are discharged to build their confidence to stay well at home, and also thinking about patient-initiated follow-up. I think it's fair to say that in order for that to be implemented safely and effectively, we need to support people to build their knowledge, skills and confidence to manage their conditions well. Next slide, please. So we've done a bit of we've been a bit generic, and now I want to focus in on how the model has been used. Thanks, Jack. How the model has been used to support people with learning disabilities or mental health conditions. So the first example is from West Yorkshire and Harrogate. And apologies for bringing in examples from around the country. We've drawn on the learning and experience of systems who are part of our Personalised Care Demonstrator programme. So they obviously have a bit more experience and they've had a bit more time to do this and to embed the learning. So in West Yorkshire and Harrogate, the Learning Disability Programme are looking at the whole model again. So looking at, for example, developing a model of social prescribing for people with to support people with a learning disability in terms of targeted interventions, thinking about how the components can be used to improve access to health checks and improve the quality of those health checks. And also at the top of the triangle, thinking about how they can expand the reach of things like personal health budgets and integrated personal health budgets to support people who are eligible for Section 117 aftercare and also people with learning disabilities. Next slide, please. This example is from Gloucestershire, and I've given you the link to the YouTube video where Nikki describes her own story, really, and she can do it much better than I can. But just some of the key things to highlight in this example. So Nikki was a high user of emergency services. She had been placed in a locked facility out of county, was considered extremely high risk and had a poor quality of life. With the help of a caseworker and a personal health budget, she now feels that she's able to direct her own care. She has accessed a climbing club where she was able to learn to climb safely. So previously she had been trying to escape from some of the facilities where she was living by climbing out, which isn't very safe behaviour, and obviously associated with lots of risk. And now she knows how to climb safely, and she's been working her way through a climbing instructor's course as well. So that's also opened up a potential career path for her. During the lockdown, she hasn't had access to climbing, so she's been able to use her PHB flexibly to access other activities, more creative activities, to help her maintain her mental health and well-being. Next slide, please. And the final example is from Hampshire and Isle of Wight. So they've been providing support to people with a learning disability and have approaches in place in both Portsmouth and Southampton. Looking at their approach to personalised care and support planning, they have provided advocacy as well for people with a learning disability, and also things like extra time for preparation of planning. They offer personal budgets and personal health budgets for people with a learning disability. They've also looked at developing the market for providers and looked at offering individual service funds. They are developing the market for skilled personal assistants as well, so that for people who do have a personal budget or a personal health budget, they can actually access support that they need, so that there is support out there. So in some areas we have had challenges where there hasn't been appropriate support available in the market for people to use their personal budget. So their experience of embedding those approaches in two areas within Hampshire and Isle of Wight, they're now in a position where they want to expand the reach of that right across Hampshire and Isle of Wight. So they're looking at using integrated health and social care teams for people with complex learning disability across the geography, and things like joint commissioning arrangements for support and housing and pooled budgets. Next slide, please. So this slide has a link to Claire's story. So Claire is a young person with a learning disability who has very complex needs and requires 24-hour support. And the video, in the video, Claire's family describe how they have used her personal budget to support her in a much more effective way that makes her much happier and much more settled. And the final slide, I think, sorry, it's building. Sorry, Jack. The final slide talks about the support available to systems from our team. So there is a Southeast Personalised Care Collaborative that's open to personalised care leads across the region. That meets quarterly, and it aims to help us share knowledge and learning and best practice. Similarly, there is a South East Social Prescribing Network that does a similar job. There is also peer support for social prescribing link workers, and that's offered monthly. There is a webinar programme. So, for example, last month we had a webinar on personalised care and support planning. Next week we have a webinar on frequent users of urgent and emergency care, and we're also planning to do one specifically around learning disabilities. So we'll keep you posted on the date for that. There is our personalised. So today we launched our Personalised Care Institute, which has a number of e-learning modules, but also supports systems to access accredited training providers that can provide training in personalised care, aspects of personalised care delivery. There are people like me. So each system in the South East has access to a delivery partner like myself, and we offer bespoke support and links into more specialist support from the wider Personalised Care Group. We have our peer leadership development programme, developing people with lived experience to take a more active role in defining and shaping our programme and helping systems to utilise and leverage the skills and experience of people who use systems so that they can help, they can be involved in designing services. And also there is mentor support for each of the elements of personalised care. And finally, the one I've missed out is on the NHS Futures platform, we have our Personalised Care Collaborative with lots of resources. And I think that's it. There are additional slides that I've added in, so that's just more information if people wanted, and links to resources if people wanted to find out more. So I'll stop there and I'll allow some time for questions if there are some.
Thanks, Marie. Okay, so if we open it to everybody, has anyone got any questions for Marie? Because there's lots of information in there, really helpful, really useful information. Thank you. Any questions from anybody?
James? Carter?
Hi, Marie. Hi.
Hi.
Yeah, thanks for that. Just looking at your support to systems, we're core to this really is that these calls is that we try to bring as many people together from those systems. Thank you, Jack. You noted some work in urgent emergency care as well. What does that look like? Just so we can get an understanding, because we're having conversations with our UEC colleagues across NHS England as well. So let's maybe just sort of try and tease that out a little bit, if you don't mind.
Yeah, no problem. And we've got a webinar next week that is focusing. So we've done that in collaboration with the I've completely forgotten the name of the program now. So the high HIU.
Yeah, high intensity users.
High intensity users. Yeah. So we've got a couple of examples. So it's talking through the sort of principles of how to support high intensity users and kind of help them change their behaviours so that they're making better choices, I guess, and more appropriate choices in terms of the support that they access. But it's in the very early stages. So we're looking at how we can use or leverage personalised care to support efforts around that. So I know that we've got people from West Kent who are joining us to describe their HIU programme, and they started to look at personal health budgets for that group of people as well prior to COVID, but obviously that's kind of been impacted by a different focus now. But certainly they have great learning to share on their experience, and I know that because the CCGs in Kent and Medway have merged, they could be looking at how that kind of works across the system. It might be useful to have a more detailed conversation at some point of how we join all of this up together. We can certainly share the details of the webinar, but it's sort of very early stages, I would say.
Yeah, no, that's good. Yeah, we'd be happy to happy to share some of those examples and you know, on the podcast. Listen to me, the webinar. So yeah, please do let us know. I come back through me, and I'll try and circle back on that. Thanks, Marie.
Yeah, no problem. Thanks, Jane. Ellen.
Thank you. Not really a question, Marie. Just to say thank you for the shout out to the Southampton, Hampshire, Isle of Wight and Portsmouth area. Just recognising that there is a lot of good work going on within our patch, but to say we're not complacent about it either, because we recognise there's still an awful lot more to do. Both in increasing the number of personal assistants that are available within the system, and in improving the number of people who take up the option of a personalised health budget. And we're doing what we can to learn from the patches, the pockets within our own patch that are being really successful, and how we share that, because as you noted in your presentation, the cities in particular are doing really well. Yeah. Thank you.
Thanks, Ellen.
Anything else? Anybody else wanted to ask while we've got Marie with us today? Just to make from a learning disability and autism perspective, to make people aware, and we will bring this back another time so we can look at the learning and share the learning. Colleagues in Surrey Heartlands have joined up with colleagues within the personal health budget team with it's Emma, isn't it? Gemma, sorry, apologies, with Gemma. And they are going to be working really, really closely with Gemma to see where we can make that link between the annual health check and the use of personal health budgets, and working into the social care prescribers that are currently being recruited to our PCNs. So we're hoping that there'll be some really good learning to come out of that, and we can look at that in the future, share that, and look at how we can support others to take similar projects forward. Yeah.
Thanks, Alison. And you know, you've got my email address, so if you've got questions afterwards, if you look through the materials and have more questions, then by all means let me know. Happy to help.
Okay, so back to yourself, James. Do you open the meeting? I don't know if there's anything else that you wanted to.
No, thank you, Alison. Thank you for leading that, and also, you know, thank you so much to Marie and Tom for offering up their time. Colleagues, if there is anything further to add, or anything that has come up as a result of these conversations, or any connections that you'd like to make, please either leave a message in the chat. Marie or Tom, if you're still on the call, if you don't mind just putting your email addresses into the chat, then people can see it. That would be great. I have recorded this, but only the section from where we're at, and actually I'll stop that now.